Hello everyone, we're Team Dolphin from the course Precision Care Medicine. Here we want to give you a brief introduction to our project, and here is a poster. We mainly focus on the early prediction of length of stay in hospitalized patients with stroke and traumatic brain injury. Stroke occurs when the blood supply to the brain is blocked. It is typically divided into two types, the ischemic stroke and hemorrhagic stroke. And as we know, it is the leading cause of morbidity and mortality globally. And traumatic brain injury, which is also called TBI, is a disruption in brain function caused by an external physical force, which is a major cause of disability, especially in children and young adults. And as we know, ICU length of stay is considered a primary driver of inpatient costs. As a result, both patients and clinicians have an urgent need for a measure of length of stay to improve ICU resource allocation and utilization, and also improve the efficiency of decision-making to ultimately reduce medical spending. And here are our objectives.
Yeah, we want to leverage machine learning techniques and determine the best performing techniques which accurately can predict ICU and hospital length of stay for patient. So in order to do that, we're going to use patient data available in the first 24 hours of stay to predict the length of stay for patient with TBI and stroke in the NCCU. And also, in order to interpredict and understand what our model doing, we're going to identify and rank predictive features driving the length of stay, driving the model. And here's the method.
So we started with analyzing the JHU PMAP, the Precision Medicine Analysis Platform. That is where we got our data from. We were considering adult patients who were admitted to the NCCU first. So here is the patient inclusion-exclusion chart. You can see, we start with 4,660 patient encounters. Here in our analysis, we are talking in terms of patient encounters is because if a patient comes into the NCCU, gets treated and is discharged, and then is admitted back again, then the patient is considered as a different encounter and as a different entry and a different data point. That is why we are talking in terms of patient encounters in our exclusion chart. So we exclude patients who are less than 18 years of age, and then we split our data set into three types: patients who experience a traumatic brain injury, a stroke, or both of them. Since the percentage of people who experience both in general is significantly lower, we exclude those patients, and then we focus on patients with TBI and stroke. We then specify the types of stroke there are, because different types of stroke are very different. So we further split our types of stroke into three: the intracerebral hemorrhage, the ischemic stroke, and the subarachnoid hemorrhage. We then run a number of machine learning models to analyze what features predict the length of stay and how these different machine learning models perform. So for the purpose of our analysis, we not only run it for all these four types individually, but we have also ran the model for the entire patient cohort together, where we consider the TB and stroke patients together, as well as where we have considered a model just for the TBI patients and just for the stroke patients. But for our results and for our poster, we have considered to showing results for the entire patient cohort. So here are more details on the inputs and output features and labels we are using.
To generate input features, we consider both social determinants of health as well as physiological data and age and other demographic data. So we would grab kind of all the vitals information from the first 24 hours of the patient's stay within the NCCU. This is important because we wanted our model to be clinically relevant. So taking data over the entire course of their length of stay would mean that we're using information the clinician might not know yet to make this prediction, which means it wouldn't be useful in the clinic. We then extracted features from all that data and then used that as inputs to our model. The outputs to our model was a binary classification decision. So a patient was deemed a 1 if their length of stay fell into the top quartile of length of stays, or if they passed away during their stay in the ICU. Otherwise, they were considering a 0. So a 1 is kind of an adverse outcome. It's either a really long length of stay or death. In terms of our patient breakdown, we can see kind of the information at the top of the poster. About 2% of our patient encounters died during their stay within the NCCU. And And then below that, you can see the results for our models. So we ran both a support vector machine, which was our best performing model, as well as logistic regression. And we can see the areas under the ROC and precision recall curves, as well as the F1 score. So we see an area under the ROC of about 0.9 for the support vector machine, and under the PR curve about 0.82. And we see that our support vector machine outperforms logistic regression and does a pretty good job of predicting ones and zeros. We kind of did a lot of things to make this work as well as it did. So we did like feature balancing or feature extraction. We did class balancing. We kind of hyperparameter tuned our models and had this kind of our final outcomes. And then on the right side, you can see our feature importance. So looking at the right graph there, that's known as a SHAP B-form plot. So what you can see is that our most important features are Glasgow Coma Scale score, temperature, pulse, the number of surgeries they've had in the past year, temperature, and other values like that. So you can see that, for example, at the very top, a high Glasgow Coma Scale score is associated with class 0 outcomes because that patient is healthier. And then you can kind of read down the chart and see that in other features as well. And then below that, we see the different performance on different patient subgroups. So like we mentioned earlier, we kind of broke down our population into TBI and stroke, as well as the 3 different types of stroke we were considering. And we see degrading performance as we break down the subgroups further and further, which we believe is mostly because of a small sample size. So by the time we break into stroke subgroups, some of those patient populations are only 100 to 150 patient encounters, which just is not enough for the model to really learn and perform well. So with that, the best performing model was the support vector machine on the entire patient cohort. But in this entire patient cohort, all the patients have features denoting if they had TBI or stroke or what type of stroke. And then they can discuss our conclusions in future scope.
So to conclude, we can say that the data which we acquire in the first 24 hours of the NCCU stay can be used to make accurate predictions about the length of stay for the patient. And we can also consider the average cost of stay in NCCU by multiplying this number by 4,000, considering that average cost is 4,000 per day. In the future scope, these models we have developed, the support vector machine model which we have developed, should be validated with external data sets from different NCCUs and different ICUs. And we understand that there is a complex relationship between the cost and the NCCU length of stay, and these complex relationships should be identified and then used to estimate the cost of the stay. Thank you.